Hello everyone. Just wanted to go through this public health notice that was released on February 26th. Long COVID biomarkers diagnosis and treatment. Very interesting. And I'm just going to kind of read through this, expand when it is that I feel necessary. So, long COVID or post-acute sequelae of COVID may affect up to 30% of individuals, as well as overlapping with ME/CFS affecting 1 to 3 million a year. Okay, now ME/CFS, myalgic encephalomyelitis, chronic fatigue syndrome, right? Serious long-term illness. This is the CDC's website, and you can see that CDC is working with partners and stakeholders to better understand post-COVID conditions. So, as the CDC shows, long COVID, post-COVID conditions, right, and ME/CFS are related. PASC represents a healthcare and economic emergency that must be addressed. Similar pathologies may exist in patients with post-vaccination injury, post-Lyme, and fibromyalgia because the symptoms are exacerbated by the S1 subunit of SARS-CoV-2 spike protein, inclusion in non-classical monocytes that persist for over a year. They may persist. So we're going to approach therapy using precision diagnostics to target efficacious therapeutics. So this is page 1. Page 2, we're going to go over the antibodies, chemokines, and disrupting the fractalkine pathway. So references on our right. This is basically a result of a talk that Bruce Patterson gave at Georgetown. His references and papers are linked here. So this is the first one, immune-based prediction of COVID-19 severity and chronicity decoded using machine learning and persistence of SARS-CoV-2 S1 protein and CD16 positive monocytes. CD16s are also considered monocytes. You might see that coming up. And post-acute sequelae, long COVID, up to 15 months post-infection. Okay. So long COVID is a very heterogeneous disease. Viral RNA shedding has been detected more than 87 days in an individual with impaired CD8 T cell responses. CD8s are your killer T cells. Low CD8 has also been notated as a result of infection and is also associated with EBV and chronic fatigue. EBV, Epstein-Barr virus, or herpes, kind of complex. With chronic fatigue, also associated brain fog, shortness of breath or dyspnea, myalgias, neuropathy, insomnia, and then overlap again with ME/CFS. Still other symptoms include POTS or dysautonomia, dizziness, tachycardia, tinnitus or tinnitus, and other mental health related issues because of the interaction of the non-classical monocytes within the nervous system. And so in general, long COVID, post-vaccination long haul, and fibromyalgia will indicate interleukin-6, soluble CD40 ligand, vascular endothelial growth factor, and interleukin-10. IL-13 and IL-4 also indicate a type 2 inflammatory response, and VEGF is highly indicated in vascular dysregulation. So these are the most, I guess you can say, seen types of biomarkers that are associated with long COVID. And the biomarkers also indicate kind of an immunologically induced pathology further down the line. Now, and they're not all the same. So what Bruce Patterson has also done is broken them down by symptom and in essence given biomarkers to confirm whether or not these non-classical monocytes are an issue carrying the spike. So the CD16 positive monocytes, non-classical, they express high levels of a fractalkine receptor. and they bind to fractalkine on endothelial cells. They can initiate inflammation due to the S1, and the inflammation leads to type 1 cytokines like interleukin 2 and interferon gamma, which are the numerators of the long haulers index that he utilizes within IncellDX at covidlonghaulers.com. I highly recommend anyone looking for further answers, or if you're looking to get yourself tested, that you go to covidlonghaulers.com. That is Dr. Bruce Patterson's outfit. He owns them, so I'm just going to send you back to the source and let you know why this is important, and just really quick break down his talk that is outlined here in this notice. So the fractalkine receptor binding leads to angiogenesis via VEGF, so the growth of the endothelial, basically, and vasodilation, resulting in head fullness, headaches, migraines, brain fog. If there's vasodilation along the nervous system, then it will also have neurological effects. Big thing is, why do monocytes live so long? Because normally they're gone in anywhere between 24 to 72 hours. So the fractalkine kind of interaction between the two causes a senescence program that non-classical monocytes no longer undergo apoptosis. Senescence means that something is living longer than what it is supposed to. Apoptosis is when the cell gets a signal to self-destruct and destroy itself, which is what you want if something is not functioning correctly. But if they have an increased senescence program that interferes with that apoptosis signal, the signal's never sent to the monocyte to die. They never think that, hey, there's anything wrong. So the idea is to block the CCR5 pathway, which is going to interrupt kind of a resetting of that senescence program and allow the cells to die. So if you're able to interrupt that receptor from interacting with the fractalkine, then that signal's never sent to the monocyte. Monocyte never gets programmed to interrupt its apoptosis signal, so the clock is in essence allowed to run out as opposed to reset. A couple of things that he uses, Dr. Patterson, within his regimen is Maraviroc. Mentioned a very good safety profile in children that have used it for years. This being a very acute type of setting where you're on maybe 30 to 90 days under the supervision and care of your own physician. It's very unlikely that you're going to have negative effects, at least not any more than you're probably already having if you're looking at using it. TMPRSS2, ivermectin, this prevents the cleaving of the furin cleavage site, so any excess spike which is out there doesn't get cleaved, doesn't expose S1. S1 never gets into the non-classical monocytes. It also helps to protect the cell nucleus from spike. You can also look at taking nattokinase, which has been shown to break down the spike protein anywhere between 4,000 to 6,000 units. NAC, which is not on here, and acetylcysteine can be on there. Again, speak to your doctor and pharmacist. There are a couple of conditions that you might have where NAC is not recommended. And then just for general immune support, glutathione, especially if you're older, about 500 milligrams a day. Glutathione is the base immune kind of amino acid, great antioxidant for you. And glutathione depletion means immune exhaustion, and immune exhaustion means that, well, you don't have an immune system anymore. And it's just, your body stops making glutathione after a certain age, so it's good to supplement. And it's also the main driver between your cytotoxic and humoral response on your adaptive immune system. Again, my name is Anthony Pena, also known as Doc Keck, Executive Director for the American Foundation for Informed Consent. Please feel free to visit us at forwardquestionshere.com. Forward is just FWD, like Frank Whiskey Delta, questionshere.com. I have legal filings, 4-part series on the pathogenicity of spike protein. We'll probably be posting this notice up there too. And if you're so inclined, I am not independently wealthy by any means or stretch of the imagination. Feel free to visit our Give, Send, Go. Give, Send, Go at American Foundation for Informed Consent. Happy to receive any support that you find especially in value in this type of work and in bringing things that you can use in your community to have an effect. So any questions that you have, happy to receive them. Many blessings. Until next time, see y'all.